Okay. So now we're going to have a very short look at dyslipidemia. So when we talked about things like hypertension, it's relatively easy to talk about treat to target, because what we're doing in the EML is pretty much actually international standards. Yeah, we use slightly different cutoffs, and we're not maybe slightly as aggressive, and we've got slightly different risk assessments potentially, but it's very, very similar. The world of dyslipidemia, though, there is a massive difference between what is written in the EML, what is written in the South African dyslipidemia guidelines. That's the one on the left here that we're using, the 2018 guidelines. Ooh. And what is recommended internationally. So the challenge with that is that you still need to obviously know what, sorry, I'm just trying to fix my slideshow. There we go. So the important thing is to try and be able to be aware of what who says, and be able to apply the right guideline in the right context. And this is probably the only place where I think sometimes it can cause confusion in our department, because it depends on which guidelines you follow, and even the risk assessment thresholds are completely different in the EML as what it is, for example, in the SAMJ guideline. So one of the challenges is that the NEML committee has gone and looked in detail at all the new recommendations coming internationally around dyslipidemia. And basically, there's very good evidence in terms of dyslipidemia management in secondary prevention. So somebody who's had a heart attack or who's had a stroke. There is some evidence in terms of the usefulness of using statins in primary prevention, but it's not as exciting as in secondary prevention. And if we do what is recommended, it's extremely expensive in terms of what we have available in South Africa. So the NEML has had to be very prudent, and has had to say, we can't follow the international or the South African guidelines because we cannot afford it as a country. So the EML recommendations for the clinics is not going to change dramatically. Okay, and I'm going to teach you both, and you need to know both. When you're out in a CHC, you will probably be applying the EML guidance. In Ward 5, you see we quite often still like to also use the SAMJ 2018 guidelines. If it's your mom, you're probably going to follow the SAMJ guidelines. If your mom's had a heart attack, and if you've got a patient who's had a heart attack, even in the public sector, you might also be more aggressive. So if you understand why we do what, where, you can make a decision. So the EML has got very short, it's literally half a page in the EML on who gets lipid-lowering therapy, because this is always the million-dollar question. Who do I give statins, and how much statins do I give, right? And they've got a simple list of patients who automatically qualify for statins. So anybody with established atherosclerotic disease, so if they've got ischemic heart disease, stroke, peripheral vascular disease, anybody with diabetes for more than 40 years, or is more than 40 years old, or has had it for longer than 10 years, that's pretty much all our type 2 diabetics, and any type 1 diabetic that's got evidence of microalbuminuria, or any diabetic who's got chronic kidney disease, so EGFR of less than 60%. And then we're going to look at Framingham risk a little bit later, or somebody who has a Framingham risk score of more than 20%. Notice this is an EML recommendation. These people you can all put on statins, no problem, and we'll look at the dosing in a minute. Then there are the patients that we're going to screen on whether they need a statin. So these are the people we're going to do the risk assessment on to see what their risk is and see, shall we put them on a statin for primary prevention? So you're going to do a risk of patient on all patients that's got diabetes and hypertension, obviously. So all of them get lipograms done. You're going to do it on anybody that's got central obesity. Remember, we spoke about that earlier as well in hypertension, anybody who's smoking, any men over 55 and women over 65 years of old. And you're going to use your Framingham calculator to be able to identify the risk of the patient. So remember, Framingham tells us what is the risk in the next 10 years that you're going to have a heart attack or a stroke, right? So it's also an easy way of how to explain that to a patient. And I've got an issue with this because they use 3 levels of risk, where everybody else uses 4 levels of risk. So the two just doesn't translate nicely between themselves, which is frustrating. So the EML uses a 0 to 10%. If you've got less than 10% risk of a heart attack or a stroke, then we can just give lifestyle advice, and we only need to do the lipogram again in 5 years. Even I find that a bit dramatic. 10 to 20%, then you will do your, still just give lifestyle, no statins yet, and you're going to do an annual lipogram. And only if the risk is more than 20%, would you do lifestyle modification and start as well, always do your lifestyle modification, and then you can start the statin. Very simple. Your dosing is going to depend on whether the patient is in a primary or a secondary prevention care setting. So for primary prevention, so those are those patients that I've just mentioned that you screen, they don't have any other cardiovascular risk events. And this is called the fire and forget policy. The EML guys actually call this the fire and forget policy. You put them on simvastatin 10 milligrams and you keep them on that bar, which means in theory, you don't even have to do cholesterol levels or see what their LDL is doing because we're not treating to target, okay? If they are on protease inhibitors, then we can't use a atorvastatin. So if you can't, simvastatin, so if you can't use simva for a reason, then that is why atorvastatin actually exists in the public sector. But if a patient has had a heart attack or ischemic heart disease or a stroke or has got peripheral vascular disease, then we use simvastatin 40 milligrams. Also Nocte, remember if they're on amlodipine, then we can't use more than 20 milligrams of simvastatin. And if they're on PIs, we're going to use atorvastatin. And again, this is fire and forget. So we are not treating towards a target. We're just putting them on that simvastatin 40. So remember, we don't have atorvastatin in the CHCs in the clinics. So your challenge is if you're in a CHC setting and you've got a primary prevention patient, we would probably be comfortable with simvastatin 10, 20 if you feel like it, for primary prevention purposes. Secondary prevention, it's a question, because we do know that the lower you get the LDL in somebody who's had a heart attack, the more it reduces their risk for future heart attacks. And simvastatin 40 milligrams, though it might not be enough. And then if you want them to go into atorvastatin, you have to refer them to your regional hospital. You have to refer them up to a larger facility. So this is where the cost starts coming into the program. A random cholesterol of more than 7.5 is considered problematic. And that's usually when we are wondering about things like familial hypercholesterolemias and you want to get specialists involved, and they probably will need atorvastatin. And we start worrying if a fasting triglycerides are more than 10. So those are some numbers to remember. Okay. Great. So let's go to the SAMJ guideline. So we have one paragraph in the EML, and then we've got this beautiful guideline who goes into quite a lot of detail in terms of when you screen, what you start, what the targets are, etc. And I'm going to run us through those. So firstly, when to do a lipogram. So that's the first question. Obviously, if you've got somebody who's even a teenager and there's severe dyslipidemia, there's a family history, we've got confirmed this family suffers from severe dyslipidemia, you could do a lipogram earlier. But basically, let's start on the other side. Anybody over the ages of 40, they would recommend a lipogram every 3 years. Okay, so that's just part of routine screening because you're becoming a little bit older. So part of your health check, so to speak. Between the ages of 20 and 40, you would do a lipogram if you are concerned. So people with hypertension, smoking, if there's family history of cardiovascular disease, if they've got increased BMIs or waist circumferences, or if they've got autoimmune disease or chronic kidney disease. So if there's risk factors, you can do a lipogram in those that are under 40. So that's like a simple guidance on when to do lipograms. The other way to think of it is in patients with, we want to be able to identify patients with metabolic syndrome. So metabolic syndrome tells us, and I'm going to do a talk next week for Rudasa on specifically around the genetics of obesity. And I'll talk then about as well, the BMI is actually fairly useless. So you can't really say just because somebody is overweight or even if they've got grade 1 obesity, that necessarily is going to make them sick. It's a lot of people who have higher BMIs who are perfectly 100% healthy and it's never going to make them ill. The way to identify whether the amount of fat cells that somebody has is actually making them sick is when they develop metabolic syndrome, which is when you start seeing the fact that metabolically, this is starting to influence their health. So the criteria for metabolic syndrome is you have to have at least 3 of the following: a waist circumference of more than 94 centimeters in men or 80 centimeters in women, triglyceride levels of more than 1.7, an HDL cholesterol, look there in men less than 1, women less than 1.3. That blood pressure you can see there, that's not hypertension level yet. If you're running at a slightly increased blood pressure, it shows this thing is starting to make trouble. or if your sugars are starting to creep up, but you're not on diabetic level yet, so what we call intermediate glucose. So the only way you can do this is if you've done a blip, you've done a lipogram, and you've done your fasting blood sugar. So the easy way to think about it is if you've got patients under 40, do your waist circumferences. If your waist circumference is increased, then you're going to do your lipogram, and you're going to try and identify, does my patient have metabolic syndrome? And do I therefore need to do a risk assessment? Great. So once we, familial hypercholesterolemia is the horrible slide. Try not to cut and paste when at all possible. And that's out of the guidelines. That's just the criteria of when you might suspect familial hypercholesterolemia. Remember, quite a big issue in some of our white male patients especially. But when you're looking at taking that lipid test, now this is a couple of tips. So firstly, do we have to take a fasting or a non-fasting version? So remember that for cholesterol levels, fasting versus non-fasting doesn't make any difference. So that's why we're happy to do random cholesterol levels. It only matters with triglycerides. And you can see that there's two different cutoffs for when we think triglyceride is high. So in a fasting sample, if it's more than 2, we would consider that high. And in a non-fasting random sample, if it's more than 1.7, and you can see it's not a massive difference. If you get somebody who comes back and the triglyceride is more than 5, then it's probably useful to do a fasting sample. But generally with most of our lipograms, you can get away with a random, which makes life much easier. Just a reminder that the LDL cholesterol in our labs are a calculation. They look at the HDL and the total cholesterol, and then they work out what the LDL is, and the triglycerides is part of that calculation. And they cannot do it if the triglyceride level is too high. So also, if you want an LDL cholesterol level, you have to ask for the whole lipogram. So I made that mistake when I first got there. I asked for an LDL cholesterol, and they did me an LDH, the lab, which was not helpful. So if you want the LDL, you have to have the full lipogram. So of course, what you want to start looking at is, never forget your lifestyle changes, but just to note that a lifestyle changes is less effective than a 10 milligram simvastatin tablet for cholesterol. So that's quite depressing. So lifestyle is amazing for things like hypertension. It's amazing for things like diabetes. There's a lot of definitely it reduces cardiovascular risk, but in terms of actually bringing your cholesterol level down, it's not particularly effective. The basic ones is all the ones you know. You're going to stop smoking. Remember that exercise 30 minutes a day every day. They have maintained that this is not evidence-based. There's nothing that says, of course, everybody with an ideal body weight, that is a good thing, but an increased body weight does not necessarily equate risk. You've got to obviously drink clean water, apparently. And I think the big thing is that just a lot of emphasis in the diet, on fiber in the diet. And if we could just win the war on processed foods, we'll probably be fine. Of course, your sugars and your salts, which is in all your processed foods, and being careful with your saturated fats and your alcohol. I'm not going to spend time on this. We'll spend time on that next week. So what the SAMJ does is it looks at, if you've identified a patient, you want to be able to identify the right patients and treat them to target. So to be able to identify who's not going to need a statin, you need to be able to stratify your risk. Then you're going to set an LDL goal based on the risk of the patient. Then you're going to calculate how much statin you need to give and which statin to be able to get to your target. And then you're going to identify this target dosing of that statin. Apologies, spelling mistake. So you can see this is very different from the fire and forget principle. And I'm just going to show you what it looks like. So firstly, you have to be able to stratify your risk. This we need to be able to do anyway. I've still taken this out of the older guidelines. There's lots of different tables on who qualifies as high and who qualifies as very high risk. For me, it's the principle that's important. So these are patients where you don't go and bother with the Framingham because we already know they're high or very high risk. So all patients who's got very high grade 3 hypertension, all patients who's got diabetes, and all patients with CKD, GFR between 30 and 60 is already a high risk patient. You don't have to go and do a calculation, right? Which means they all qualify for statins. Very high risk are those people who's already had an event like a stroke or a heart attack, people who've got complications, people who've got very high cholesterols or triglycerides, and those with severe CKD. So there's lots of tables, but the hypertension guidelines has got tables for risk. There's a, this is in the KDIGO guidelines for chronic kidney disease, and you can see they use the same 4 colors, right? They've got a low risk, moderate risk, high risk, and very high risk. And depending on your proteinuria and depending on your GFR, they will set your risk for cardiovascular disease. So you need to just figure out, for my patient, where do I think they sit? If you're not sure, so they're not high or very high risk, that's when we do our Framinghams. Have all of you done Framinghams? No, not familiar. They don't do them in the internal medicine department, really. These are in the EML. There are calculators, but you've got to be careful on which calculator you use, because the original Framingham was done on a massive amount of epidemiological data, and I think it was done in Britain originally. So on thousands and thousands of people is how they got these mathematical formulas together, and they have been adapted for a South African setting. So if you want to use the tables, you can use the tables either in the guideline, they're also printed in the handy reference tools, or the one that's in the EMG, they're all the same. And the way it works is, you'll notice on the left here, that's a table for men, and on the right here, there's a table for women. So we look at the age, and I love doing this with patients. Can you even see that? Not really. When you sit down with a patient, the patient themselves can see what creates risk. So for example, if you're 30 to 34 years old, you get 0 points. But by the time you hit 50, you get 7 points. So my risk is just jumped by 7 points just because I'm older. So it's helpful to say to patients, listen, you're fine at the moment, but in 10 years, it might not be fine as you grow older. Then they look at total cholesterol levels. HDL cholesterol is one of our healthy cholesterols. It actually reduces your risk. Anybody know how you get HDL up? Simon? Exercise, excellent. So that is how you get your healthy cholesterol up. If you want to balance out some of your unhealthy cholesterols, and you can see you can actually get a negative value if your HDL is very high. So if you do exercise, it makes you younger. Yeah. And then depending on your systolic blood pressure, depending on whether or not you're on treatment. And then of course, if you're a smoker, you get a whole bonus extra 3 points. So this gives you a number. And then here on the right, you're going to use that number to give you the 10-year percentage risk. Once you've got a 10-year risk, you get this lovely table. And you can see this was actually, it's in the guideline, was created to actually give to the patient. So you can actually fill your scores in there. You can put your risk in there. And now you can see there's 4 groups. So remember the EML at 0 to 10, 10 to 20, more than 20. Everybody else uses either less than 3, 3 to, which is low risk, 3 to 15%, which is moderate risk, 15 to 30%, which is high risk, and then more than 30%, which is very high risk. So if you look at the low risk, the less than 3%, you can see there that it's about lifestyle changes if they're low risk. And under this guideline, it would say you would only consider statin if the LDL cholesterol is persistently over 4.9. So you've got time to look at diet and exercise and what else is going on in this person's life before you start putting them on statins, especially important in your younger patients. If you've got a moderate risk, so your risk is between 3 and 15%, you're always going to do the lifestyle changes, but now you will only consider a statin if the LDL cholesterol is persistently over 3. So again, you're going to do your lipogram, you're going to tell the patient, oh, you know, you might need to get a bit healthier, get a bit fitter. You're going to check your lipogram again 3 months later, and you can decide, depending on the risk factors, how long do you take before you go, okay, your LDL is always over 3, maybe we should try and add in some statin and see if we can get it under 3. If your risk is between 15 and 30%, you can see they've reduced that threshold to 2.5. But in those patients, as soon as you've got a risk between 15 and 30%, if your LDL cholesterol is over 2.5, you give a statin PAR. No questions asked. And once the risk is over 30%, all of them get a statin. So this is the 2018 guidelines. And the international guidelines have completely revised these goals. So these are the other goals you'll be hearing about when you're in our department, and this causes much debate. So for example, low risk is still less than 3, but moderate risk, this group, they've reduced the LDL cholesterol goal to 2.6. They've reduced this goal to 1.8, and all of them, so if it's more than 1.8, you will start that statin. And for the high risk, they've actually put that risk to low to less than 1.4. And anybody who's had an event like a heart attack or a stroke, the idea is to try and get that LDL cholesterol as low as absolutely possible. To be able to achieve these targets will take bucket loads of atorvastatin. So this is where you're making those individual decisions when the patient is sitting in front of you. So this is where it gets very posh. So what you do is when you now have a patient and he's got a cholesterol of 3.6 and you've set a target of 1.8 because this patient is a high-risk patient, then you're going to have to look at, well, how much do I need to bring my LDL down? So I need to reduce my LDL. My LDL is more than 50%. I need to bring it down by 50%. And there's tables in the guidelines, huge, that tells you the percentage of reduction that you're trying to get and what drugs will best do it. So if you want to reduce the LDL cholesterol by less than 30%, then you can, simvastatin 10 milligrams will probably do it. If you're trying to reduce that LDL between 30 and 50%, you're probably going to need simvastatin 20 to 40, or you're going to need some atorvastatin. But if you want more than a 50% reduction, you are going to need atorvastatin 40 milligrams to get that done. So the idea is you will already decide, this is what my patient's going to need. And you might start on a lower dose because of side effects, but you will build them up over the 3 months to the correct dose. Rather than waiting for because you can only do a lipogram every 3 months, waiting for the lipogram, upping your statin, waiting 3 months, upping your statin. So it's a way to already set your target statin. So the idea is in our setting is that we usually start with a lower dose and we up titrate, and you're supposed to ideally at 4 weeks go to that targeted dose. But in our setting, I know the pharmacist also is a little bit nervous about switching somebody to atorvastatin if you don't have evidence it's a simvastatin 20. You normally have to say, okay, I'm not winning with simvastatin before you're going to be able to motivate or justify to put a patient on atorvastatin. The recommendation and the guideline is to do a lipogram between 4 to 8 weeks, but unfortunately in NHLs, it's gate kept. You can't do a lipogram less than 3 months. They won't do it. So we in our setting, we're not able to do that. The idea is, and then once they're at goal 6 monthly, I'll show you our intervals in a minute. So just a couple of words about our actual statins. So simvastatin, you get 10, 20, and 40 milligram tablets. We do not use more than 40 milligrams per day. That's our maximum dose, but do feel comfortable to go up to 40. It's a short acting, so it's something that's actually best to be given at night. And there's no dosage adjustment needed for any degree of kidney impairment, which is nice. So it's all contraindicated in active liver disease, but it must be quite severe liver disease, or they've got transaminases that's high and you don't know why. So that's about the only real contraindications. Atorvastatin is got larger sizes tablets, 10, 20, 40, and 80 milligrams, and you can give it either in the morning or the night, which is quite nice. And the equivalent is that 20 milligrams of simvastatin is probably as strong as 10 milligrams of atorvastatin. So that's just helpful when you're upping your dosing. One with simvastatin is various drug interactions. So amlodipine and then simvastatin, also not friends. And also the protease inhibitors, and luckily with the protease inhibitors as well, we're slowly getting rid of those. But just to be aware of that when you've got your patient on statins. So in our scenario, if you want to think quickly in terms of doing lipograms, healthy patients over 40 years that we are screening, you're going to do a lipogram every 3 years. If the patient's over 40 and they've got metabolic syndrome, but they don't have any other risk factors, then you can do an annual lipogram. Once they're on a statin, then you're going to do a lipogram every 3 monthly when they're not yet on target while you're trying to get them onto target. And then once they're on target, you can do a lipogram every 6 months. And that gives a very quick summary of dyslipidemia. Thank you very much. So I hope I haven't actually confused you too much, because I've just taught you two completely different guidelines that you're going to use in the same setting. I think feel free to ask when you've got patients in front of you, but this will become particularly useful when you're out in the districts or out in the hospitals. And you're going to have to figure out, what do I have available in my hospital? What's possible for my patient? What do I think the risk is for my patient? And how am I going to best manage the patient in front of me? Any questions? Yes. So familial hypercholesterolemia, if the cholesterol is over 7.5, it's not so much a cutoff, then you're going to become suspicious. So it's not that they have it, but you might then want to go and find out, is anybody in the family, so they say a second-degree relative under the age of 50 had a heart attack or stroke, or a first-degree relative under the age of 60 had a heart attack or stroke. So you want to start getting some history of what's happening in the rest of the family if the cholesterol is over 7.5. I mean, in Europe and stuff, they do genetic testing. So you'll actually have a genetic test done to confirm whether you have it. And we do have it in certain families in South Africa. So it is one of those things to be aware of. Oh, someone says you can feel the Achilles tendon. Yes, that's right. And if they've got xanthomata, for example, if they're young and they've got obvious xanthomata, or they're very young and they're developing cardiovascular disease with a high cholesterol, in our setting, we'll obviously use those as criteria to say, we assume this person has familial hypercholesterolemia. And then you would actually treat quite aggressively because they have a very high risk of an ongoing disease process.
For some reasons, it's quite useful to say that. For some reasons, it's quite useful to kind of, a lot of people have noticed, like, especially in Ward 5, because this rotations out, rather than following up the same list. I really do, and this is trying to make sure that it does happen. We're about to distribution the past. But sometimes it can be right to target in, right?
Yes.
Because that's quite useful. And then if the patient's not on target, you can say patient will be there for the fire statin.
So very important. Generally, when you write don't ever do this thing of looking back and rewriting somebody's little list on the top of your, the hashtag thing, right? If you're going to hashtag, when you create that list from scratch by chatting with your patient. So I always go back and see, oh, they've got hypertension. And I'll say to the patient, oh, you've got high blood pressure. How long have you had hypertension? And then you check, are they on target today? So then you write in, okay, I've got confirmed. So if you see, I look down for furosemide, check if they got heart failure, look back if there's an echo, so that when you make a list, don't just do a rewritten list. Sometimes we have anemias, et cetera, et cetera. So if you've got a patient who's got dyslipidemia, then you will write on, you'll look back, you go, okay, there's dyslipidemia, you'll ask the patient, you look at what treatment they're on. As soon as you write dyslipidemia, you have to write down the Framingham risk. And ideally, the risk should have been done before they were put on statins. That also gets complicated because you sometimes don't have history back that far. You want to try and get a baseline, as close to a baseline Framingham risk as you can before we started the statins. And then, yes, ideally, you want to decide on your target. Gets tricky because some people use the international target, some people use the SMJ target, some people use the EML target. So it might be useful to just, if you have the risk, then somebody will be able to see, okay, this person has decided to treat them on international targets, and I have no solutions on how we decide which targets we follow. This has been one of those interesting debates that we've had in the past.